All right, last week we talked about assessing pregnancies at risk, and we looked at fetal well-being and conditions that were already present or that could put the pregnancy at risk pregestationally going into gestation. Chapter 21 is going to be looking specifically at gestational conditions, what things happen when you're pregnant that puts the pregnancy at risk. Hypertensive disorders of pregnancy are the most common medical complication reported during a pregnancy. Preeclampsia complicates anywhere from 5 to 10% of all pregnancies, and hypertension is a significant contributor to maternal and perinatal morbidity and mortality. Hypertension in pregnancy has been divided into different classes or categories. The ones we're going to talk about: gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and then preeclampsia superimposed on chronic hypertension. It's important to note that standard definitions are not consistently utilized by healthcare providers, so you can appreciate the challenge that that's going to be in taking care of patients, or whenever you cross providers, using a multi-disciplinary approach, or involving multiple practitioners in an OB patient's care. Gestational hypertension used to be referred to as PIH, or pregnancy-induced hypertension. As a matter of fact, some of you probably saw PIH in some of the OB charts this semester while you were in clinical. But GHTN, gestational hypertension, is the onset of hypertension without proteinuria that occurs after the 20th week of pregnancy. So she's halfway through the pregnancy and her pressures start going up. Diagnosis is based on 2 blood pressure measurements that meet the criteria for gestational blood pressure elevation within a 1-week period. Okay, so if her systolic is greater than 140, diastolic greater than 90, that's elevated blood pressure. If she has that repeated, then we're looking at gestational hypertension as opposed to just a single elevated blood pressure. You got to think about when these women are coming into the office for a visit. You send them to the bathroom, you have to get a urine sample to check for protein and sugar. So especially as the pregnancy advances, it's going to be lumbersome. They've got to get in, they've got to pull the pants down, they've got to sit down, then they've got to clean themselves, and they've got to stand up, pull their clothes back up, get everything back in place. Then they go and sit down in a chair, and almost immediately somebody's slapping a blood pressure cuff on them. Well, if you don't give them the opportunity to just sit and chill and normalize for a second, you may have an elevated blood pressure. Okay? So you want to make sure that you're taking it appropriately, not after it's just been exertional. Now, preeclampsia is the hypertension after 20 weeks, so the gestational hypertension. However, you're going to have protein involved with it. So she'll start spilling protein in the urine after 20 weeks of pregnancy. There's mild preeclampsia and severe preeclampsia. And, one of the big things that they look at to differentiate between the two is going to be the proteinuria, what they see. If they're doing a dipstick urine, if it is 1+ on a dipstick, that's going to be somewhere around 30 milligrams of protein. 1+ is considered mild. Now, I will tell you, a lot of times in practice, we would wait until 2+ before we started being worried about it, for the simple reason that with 1+, it may be that they didn't clean well with the little wipes that you send them in with, because they've got the leukorrhea, they've got the discharge, they've got just the increased everything down there. That can give you a false elevation in your protein. So if you get a 1+, then you might send them back and have them do it again. Okay, but if you have persistent dipstick elevation, or you do a 24-hour urine and there's at least 300 milligrams of protein in 24 hours, that's mild preeclampsia. Severe proteinuria is when you have a 3+ or more dipstick, or you have 5 grams of protein in a 24-hour urine. If I ever got somebody with a 2+ urine protein, I would send them back to the bathroom, do the specimen again, just make sure everything was nice and taken care of. If it was still elevated, I might then do a straight cath, or if they say they couldn't go to the bathroom again because you know they still got some residual in their bladder, you're going to do a straight cath. You want to be sure, am I really looking at proteinuria or not? Because if it is, that's immediately a physician consult. Pretty much the distinction between preeclampsia and eclampsia is seizure activity. So with eclampsia, you have seizure activity or coma in a woman who is diagnosed preeclamptic and has had no history of seizure disorder before now. The presentation of the preeclampsia will vary. 1/3 of the women will have seizures during labor. 1/3 will have seizure during delivery itself, and then 1/3 will have seizure activities within 72 hours after having the baby. It is still important to remember that that 72-hour mark doesn't mean that all risk for seizure activity goes away, though. She is still at risk for seizure activity for up to a month after she delivers, at least. Now, chronic hypertension is the woman who has pre-existing blood pressure, so it's like a pregestational situation, or she develops hypertension before 20 weeks. Okay, so just to differentiate, remember gestational hypertension is onset of hypertension after 20 weeks. Chronic hypertension is either pre-existing or it develops before 20 weeks. So there was an underlying predisposition for it there anyway. The woman with chronic hypertension does not have proteinuria. Now, kind of like gestational hypertension to preeclampsia, if the woman with chronic hypertension develops proteinuria, then she has the superimposed preeclampsia. And that carries the same concerns and risks and potentials and necessary management practices as does preeclampsia, because we don't want to progress to seizure activity. Really, we don't necessarily know the exact why people get preeclampsia, because if we did, we would do as much as we could in our power to prevent it. But that's why we have to do screenings and watch the patient all throughout her pregnancy, because you never know when it's going to show up. Now, preeclampsia, it's unique to humans, okay? Not just mammals, or at least we've never seen it in any other mammal outside of human pregnancies. Because preeclampsia is a condition that develops after 20 weeks of pregnancy and it has the proteinuria, it stands to reason that the signs and symptoms are only going to show up during pregnancy. Now, once we deliver and we lose the pregnancy and we lose the hormones and we lose the triggers, the signs and symptoms disappear after birth. It's important to remember it's not going to be immediately after birth. We still have risks for up to some weeks after birth. Now, things that are considered risk factors that can be associated with preeclampsia, one of the things we talked about last week was Bell's palsy, that there has been a correlation seen in risk for preeclampsia and Bell's palsy. If this is the first time a person's been pregnant, that puts them at risk. If we have a multifetal pregnancy, twins or trips, that's going to be a risk. Your obese person and or someone with a pre-existing medical condition, remember the diabetes we talked about, is there a risk for it with that? If they've had preeclampsia in a prior pregnancy. So, you look at the very first risk factor is this could be the first pregnancy, but then if they had it once, there's always the potential to have it again. A risk factor that's not put on here is age. Your younger adolescent pregnancies, they do have a risk for preeclampsia, and then your older population, your advanced maternal age, have a risk for it as well. So here you kind of see a diagram mapping out preeclampsia. With the pathophysiology, there's the consideration that it may be caused by disruptions in placental perfusion and the endothelial cell dysfunction. The main pathogenic factor is not an increase in blood pressure, but the poor perfusion that results from the vasospasm. Your arterial vasospasms diminish the diameter of the blood vessels. That's going to impede blood flow to the organs, and you're going to have an increased blood pressure with it. You will see significant decreases in placental, renal, liver, and brain functions. So to make sense of it all, let's take a look at the diagram. All right. First off, the spiral arteries do not change their structure. They're, thick-walled. They should relax, become thin-walled to be able to handle the increase in circulating volume. Well, that doesn't happen, so you have diminished perfusion to the placenta. The placental ischemia, resulting from the decreased perfusion, releases toxins, and those toxins will affect the endothelial cells, resulting in endothelial cell dysfunction. The result of the endothelial cell anomalies related to the toxins is going to be vasospasm, increased peripheral resistance, and increased cell permeability, all of which is going to lead to decreased tissue perfusion. There are many consequences resulting from the endothelial cell dysfunction, and the diagram here is going to map out pretty much all of them for you. With preeclampsia, the albumin is lost in the urine, so you have proteinuria. This results in a decrease in the plasma osmotic pressure. The intravascular volume will drop when the fluid moves out of the vascular and it moves into the tissues. And this is going to result in edema. So your patient's face, hands, feet, legs, everything will be swollen. And you're going to have hemoconcentration, so you'll see an elevation in your hematocrit. The decreased liver perfusion results in liver damage, and you're going to see this reflected in an elevation of your liver enzymes. So that's why they always do LFTs when they're worried about gestational hypertension and preeclampsia. If severe, with the liver perfusion, if the damage to the liver is severe, she may experience either epigastric or right upper quadrant pain. And then the neurologic component that we're worried about. Headaches, you may see those as early signals. Hyperreflexia, which is just going to be very brisk, deep tendon reflexes. You may see clonus, and an end result which transitions preeclampsia to eclampsia would be your seizure activity. HELLP syndrome is often nonspecific in its presentation. You don't see demonstrated the changes of preeclampsia clearly enough to have you readily identify what's going on. For instance, her blood pressure may only be slightly elevated, and she may not even have the proteinuria. So you can imagine that this patient, may very well go undiagnosed if her chief complaints are really just more a fatigue, general malaise, almost kind of things that you might expect a later term pregnancy woman to have. A key characteristic of HELLP syndrome, to kind of focus you in on it, is going to be the epigastric or the right upper quadrant pain that she has because of the associated liver injury. So what exactly is HELLP syndrome? Well, HELLP really is just the acronym to make you think about what laboratory screens, tests, variants are you going to be expected to see with your severe preeclampsia. You're going to have hemolysis, so that's the first H, or that's the H. Elevated liver enzymes, remember we've got liver damage going on here, and then low platelets. It's interesting when you think about the platelets, because with HELLP syndrome, the platelet count is going to be low, but your prothrombin time, your partial thromboplastin, so PT, PTT, and your bleeding times remain normal. And while traditionally, classically, you see the hemolysis, so that's the first H, it doesn't always occur, so this may be referred to as a partial HELLP syndrome. Associated HELLP's been associated with risk for pulmonary edema, renal failure, DIC, so you definitely have to worry about bleeding disorders, placental abruption, liver hemorrhage or liver failure because you have the liver injury, sepsis, and stroke. HELLP syndrome is associated with an increased risk for maternal death, with perinatal mortality rates going anywhere from like 7.5 to 20.5%. The rate of preterm birth with women who have HELLP syndrome is approximately 70%, and 15% of these can occur before 28 weeks. So, that's pretty significant. And most of the perinatal deaths that occur before 28 weeks in association with abruption or severe IUGR. So whenever you are checking out your patient, worried about blood pressure issues, gestational, chronic hypertension, preeclampsia, whichever, your assessment is going to be very important, okay? One of the key things is that you have to be consistent when you're taking your blood pressure on your patient. We want to do these manually. We don't want to use electronic devices because they're not as accurate. And you think, well, it's technology. It's supposed to be better. It's not. Trust me. You need to do manual pressures. Positioning your patient is important. You want to make sure that the blood pressure cuff is on the upper arm and that it is in direct line with the heart. You also want to make sure that you're using the right sized cuff for your patient. I've even had to get thigh cuffs out before to go around someone's upper arm if they had a very large upper arm. If you have too small a cuff, you're going to get a falsely elevated reading. The timing of when you do the blood pressure check is going to be important just in the sense of when they come into the office. It's very standard that the first thing we do with women when they're in the office is to have them go and get a urine sample. We're checking for sugar and protein. But depending on how advanced they are in the pregnancy or how big they may be, that can be a workout in and of itself, just getting the clothes up and down and standing up and down. And if you plop them in a chair and take their blood pressure immediately, there's a good chance you're going to get a falsely elevated pressure. Edema, really and truly by the governing bodies, A1, ACOG, edema isn't really looked at as a criterion anymore for preeclampsia. However, it is still very noteworthy, and you need to be able to differentiate, what's a dependent edema versus a significant, pitting edema. Think about yourself. If you've been on your feet all day or you've been sitting all day, your feet and ankles may be a little swollen. That's dependent edema. The fluid's going to go to the lowest point. But if you have facial edema, periorbital edema, just all over, or it's pitting, and we'll see pitting on the next slide, that's going to be significant, okay? Deep tendon reflexes and clonus is an assessment that you're going to be doing, especially if you're worried about progression of preeclampsia and that neurological involvement. Deep tendon reflexes are going to be anywhere from 0 to 4+, 0 is absent, 1's diminished, 2 is normal, it's what you expect, 3 is hyperreflexive on up, and then you can get clonus, which is where you continue to have the reflexive beat or movement of whatever you've just assessed. Usually they say clonus of 3 beats or more is significant. Now what I have done is inserted a little YouTube clip it's not of a pregnant person, but it is very good of an assessment of looking at deep tendon reflexes and then seeing what clonus is. So I want you to be able to see that, and if for some reason the link doesn't work, it does for me, but if it doesn't work for you, then just copy and paste it into your web browser so that you'll be able to see it. It's really a good video, about 3 minutes long. And then your laboratory tests, your liver function test, your platelet count, those are going to be your standard, because remember we're looking at, and your H&H. You're wanting to know about HELLP syndrome, the hemolysis, elevated liver enzymes, and low platelets. So obviously you're going to do LFTs, you're going to do a platelet count, and you're going to get an H&H. So here you see assessment of pitting edema in the lower extremities. So you can do this on the front of the leg over the shin. If it goes down 2 millimeters, it's a 1+, 4 millimeters is a 2+, 6 millimeters, it's a 3+, and if it indents 8 millimeters and it stays down, doesn't come back up, that's 4+ pitting edema. So you should have watched the video and you saw the gentleman do assessment of DTRs, or deep tendon reflexes. If you paid attention to when he was doing the bicep tendon reflex, what you see in picture A here pretty much goes over that for you. So the practitioner provider would put the thumb over the biceps tendon, and the hammer strikes on the thumb, not on the patient, to see what kind of reflex response that you get. B is the patellar reflex. That's one we're all familiar with doing. It's important that what you're looking at really is what the quadricep muscle is going to be doing. So you're going to see the lower leg kick out, but what you're really assessing is that quad muscle. So sometimes you can put your hand on the thigh, and then when you strike with the patellar hammer, you will actually feel the muscle contract. And then C is getting ready to assess for clonus. So you saw how, he pulled the foot back, so we want to see how many beats of clonus, how many times that the dorsiflex foot just continues to spasm. In this situation, the mother has to be able to care for herself and observe for progressions of symptoms with mild gestational hypertension or mild preeclampsia. While partial or complete bed rest is still being advised by some practitioners, that is not an evidence-based practice in approving the pregnancy and neonatal outcomes. Alternatively, the recommendation is to have restricted activity instead of complete bed rest. She can also follow a regular diet if she's mild preeclamptic. She doesn't have any sodium restrictions or anything like that. She will be allowed to follow a normal progress to spontaneous labor. If she gets to be 40 weeks and she hasn't delivered, then she can be induced. If there are concerns about the fetus, with the well-being, are things going on well, if we don't want her to progress from mild to severe, if the cervix is favorable and she does have mild preeclampsia, then induction can occur as early as 37 weeks, because technically that has gotten into the term range. I want you to keep in mind that the ideal time for the fetus to be in utero is 39 to 40 weeks. But if there's more risk to the fetus being inside mom as opposed to being out, then you're going to induce. Your fetal surveillance is going to include daily kick counts by the mom and either NSTs or BPPs 1 to 2 times a week until birth. And again, these are going to be starting sometime around 34 to 36 weeks gestation. You will do an ultrasound to assess the amniotic fluid volume, because remember, that's going to give you information about placental perfusion, and if you see oligohydramnios, you're going to deliver. Your mom may undergo a 24-hour urine, because we want to see the progression of the protein in the urine. Remember, the dipsticks aren't always as accurate, so if you can get a 24-hour urine, you will be able to see, okay, do I still have that 300 milligrams, or am I hitting up to the 500 grams, which is going to be transitioning into severe. If diagnosed with severe preeclampsia, the woman should be hospitalized for at least 24 hours for surveillance of both her and the fetus. So we will have EFM going for continuous fetal surveillance. She's going to have vital sign checks, neuro checks, abdominal assessments looking for uterine, epigastric, or right upper quadrant pain. We're going to be looking at vaginal bleeding. I mean, she's hypertensive. We're worried about abruption here, so that's where the uterine pain would come in. And then the labs, remember, proteinuria, so possibly a 24-hour or at least a straight cath or something, and then the H&H, LFTs, and platelet count. If she is less than 34 weeks and we need to deliver, if there's time, we're going to do steroids to promote the fetal lung maturity. Sometimes you have to go ahead and just deliver and manage neonatal respiratory distress. In the hospital, severe preeclamptic patients will be on strict bed rest. There will be seizure precautions implemented to reduce neurostimulation and hopefully the progression to eclampsia. So, dim lights, quiet environment, limit visitors to even keeping visitors away. The bed rails, you need to have them up. You need to make sure that they are covered so she doesn't injure herself, suction in place, all of those things. To prevent the onset of seizures, the providers will start her on mag sulfate. You need to remember that mag sulfate is used for neuroprotection, not to drop blood pressure. You do get the added benefit that mag seems to work to have the blood pressure drop because of the effect that it has on vasculature, but mag sulfate in this situation is used for neuroprotection. She'll get a loading dose, 4 to 5 grams. That will be infused anywhere from 15 to 30 minutes, and then it's going to be followed by a maintenance dosing of 2 grams an hour. You're looking for a therapeutic level of 4 to 7 milliequivalents a liter. So that's where we want to go for seizure management. When you have somebody on MAG, normal side effects that you can expect are going to be warmth, flushing, burning at the IV site. Toxicity signs or symptoms will be lethargy, decreased or absent deep tendon reflexes. Urine output less than 25-30 milliliters an hour, because it's going to be should be excreted through the kidney. So if her urine output's down, then that means that she's building up circulating mag levels. Slurred speech, bradycardia, bradypnea. If her respirations are less than 12, that's significant. Worst case scenario, she's going to have cardiac arrest from it. We want to get her blood pressure controlled, looking for 140 to 155 over 90 to 105. Inpatient providers seem to use IV hydralazine as the drug of choice, but research is showing us that IV labetalol or PO nifedipine can be just as effective, and they have less side effects, but still they seem to go with the hydralazine. Once she is delivered, the MAG will continue for 12 to 24 hours because she's still at risk for seizure activity. You're going to continue to do all the assessments that you did in labor, intrapartum. You're going to do urine output evaluations. You're going to be checking MAG levels, doing neuro assessments. You're going to watch the lochia for hemorrhage, because the MAG actually can promote uterine atony. Uterine atony, #1 cause of postpartum hemorrhage. But you got to remember from what the preeclampsia does in general and causes the hemoconcentration, she may not be able to tolerate the loss that she has of the blood and everything. So you definitely want to keep up with observation of the lochia. Postpartum meds that would be used to control the blood pressure, again, your nifedipine, labetalol, or methyl-dopa. As we said earlier, followed by a drop in her blood pressure and then an ensuing coma. Safety is going to be very, very important in this situation. You're going to turn her over to her side when this is happening. You don't want her laying on her back. You want to make sure that she has a patent airway. Don't go sticking your fingers down in her mouth or anything like that, because you don't want her to clamp down on you, obviously. You got to think about, she is eclamptic, she's seizing, she's not breathing. If she's not breathing, the baby's not breathing, so you've got to make sure that airway is open, have the oxygen right there. And then post-seizure decision regarding the timing and method of birth, and it's really a no-brainer about the method. She's going to have a cesarean because the only treatment for this is birth. It's just when. She's going to be in that post-ictal seizure phase, so you've got to let her at least stabilize down. Anesthesia is not going to just go in and immediately get into something unless it's truly a life or death situation. You may use general anesthesia in this situation. You obviously don't have time to play around, and there may not be enough time or safety considerations using anything other than general anesthesia. The HELP syndrome, the DIC that we have to worry about, again, if she has low platelets, what are you going to do with your clotting factors? You have to worry about that. If she has DIC, she may be bleeding out. She is hemolyzing red blood cells. She's using up all of her coagulation factors, and so she can't stop any further bleeding. So you may have to do blood replacement products in this situation. Distinction between preeclampsia and eclampsia is the onset of seizures. So what will you be looking for? What will you tell a mom to be looking for that could indicate the transition into eclampsia? Well, headache. So, is it a mild headache? Is it a headache that is unresponsive to interventions? Is she having any visual disturbances with it? Is she, having the floaters, blurred vision, losing vision, out of one eye? Again, the epigastric pain. Think about your liver injury, liver insult, the hypoxia, decreased perfusion. So you're going to have elevated liver enzymes. You're going to have epigastric pain, right upper quadrant pain with that. And then the altered mental status. You will see tonic-clonic convulsions. All right, so the woman who comes into the pregnancy with hypertension or who gets it in the first half of her pregnancy, we need to keep a close eye on her. We do have the concerns of placental abruption. If she's hypertensive, we got persistent hypoxia, decreased perfusion to the uterus and the placenta. We can have some abruption going on. You can get the progression, get the proteinuria, so you have superimposed preeclampsia, obviously an increased perinatal mortality, and if you have decreased perfusion to the placenta, stands to reason you're going to have a reduction in the micro and macronutrients and the oxygenation to the fetus, so you're going to have intrauterine growth restriction and small for gestational age babies. Ideally, management of chronic hypertension is going to begin before conception, so that preconception counseling is going to be very important with this person. She may need to enact some lifestyle changes. She may need to get weight under control, or if she's on medication, become more compliant with it. In postpartum, we have to watch her to make sure she, doesn't progress into preeclampsia or eclampsia or have any other blood pressure worsenings. And the good news is she will be able to breastfeed because even though low levels of the antihypertensive meds have been found in the breast milk, it is still going to be safe for her to breastfeed the baby. Alright, so Hyperemesis Gravidarum, or HEG, can be seen as early as 4 weeks, and generally is going to be over by 20 weeks, but there are some women who may experience symptoms throughout the pregnancy. While nausea and vomiting can be a normal occurrence in pregnancy, especially in the first trimester, if she's got accompanying weight loss, electrolyte imbalances, and ketonuria, then it's HEG. Associated risks for having HEG will be a multi-fetal pregnancy, so twins, trips, any multi-gestation. Chromosomal abnormalities like your trisomy 18 or 21. If she has gestational trophoblastic disease, if she is overweight or obese, if this is her first pregnancy, or if she has history of migraines. Clinically, she's going to have dehydration and significant weight loss. Notice those are bolded. Those are two things for clinical manifestations you need to be aware of. In assessment of the nausea and vomiting, you're going to be looking at the frequency, the severity, the duration. What makes it better or worse? What has she tried and succeeded and tried and failed? Does she have anything else going on? Is there any diarrhea associated with it? Is she having abdominal pain or bloating? Is it a febrile illness? You want to get baseline vital signs and weight, because that's how you're going to track her changes to determine if she has weight loss. Is it significant? To be able to see, are there clinical signs and symptoms of dehydration present? If she is unable to keep down clear liquids, then it's very possible that she's going to need, and probable actually, that she's going to need IV fluids to correct the fluid and electrolyte imbalances that she would see. In the past, historically, women would have to go into the hospital to get IV fluids, but now we know that this can be done on an outpatient basis. You don't really think about central lines being used in pregnant women, but a PICC line is something that is being seen more commonly, because they can have the PICC line placed and then they can get IV fluids, 2-3 times a week if they need it, without having to have the multiple sticks. Whereas before, women might be going to the hospital, to the emergency room or something 2 or 3 times a week just to get IV fluids. Medications that might be used to control the nausea. Vitamin B6 is something that's coming back again. Antihistamines such as doxylamine, promethazine, your metoclopramide. These are all generics. So you've got your Unisom for your antihistamine, Phenergan, Reglan is the metoclopramide, your prochlorperazine or your compazine, or you may have the ondansetron or your Zofran. Generic names are so much harder to say. Now, once the emesis has stopped, so she's not throwing up anymore, she's able to tolerate liquids, you want to have a slow progression to a nutritionally sound diet. So typically you're going to start off with clear liquids, and you're going to do clear liquids for 12 to 24 hours at least, with no throwing up whatsoever. If she ever throws up, you have to start all over again. So clear liquids to begin with for the first day. The second day you'll progress to full liquids. If she can tolerate full liquids for 24 hours, then you'll progress to a soft bland diet, and after a couple 3 days of just a soft bland diet, you will transition into a regular diet. If you look on page 642 in your textbook, down at the bottom, you'll see a little box that will detail patient instructions for following an HEG diet. Well, it stands to reason that any hemorrhage event is going to be considered an emergency in pregnancy or even in the postpartum. I mean, you've got to have the blood, because you've got the hemoglobin in the blood. The hemoglobin is your oxygen transport. We know that oxygen perfusion for the mom and for the fetus is crucial to a successful pregnancy and successful outcomes. So if you have hemorrhagic disorders, you have obviously the risk for hypovolemia if she bleeds out, associated anemia, infection. If you're hemorrhaging and she's not delivered, then you're preterm labor and birth resultant from that. Fetal risk will also include the blood loss or the anemia. Fetal hypoxia and anoxia, you're going to have fetal acidosis, so you're going to have a sick neonate at birth. And again, if the fetus is acidotic, then that may trigger a preterm labor and preterm birth. So any bleeding in pregnancy is considered abnormal until identified and, I guess, theoretically explained. Now, early pregnancy bleeding is anything up to 20 weeks, which is going to be an abortion. Remember, you've got your para up to 20 weeks. It's considered an abortion. After that, it's considered a para because of the viability. 10 to 15% of clinically recognized pregnancies will actually end in a miscarriage or a spontaneous abortion. When you're categorizing the different types of miscarriages, you're going to look at threatened, which is simply there is bleeding in pregnancy, but the cervical os is closed. Inevitable is the woman who comes in bleeding and you see the vaginal bleeding, you do speculum exam, the cervical os is open and dilating, so you can imagine that the uterine contents are going to be expelled. A complete miscarriage or a complete abortion is where the uterus empties itself of the products of conception. So everything has been evacuated and the os has closed back up again. A missed miscarriage is where either the embryo or the fetus has died. There's been a demise, okay? However, the body has not expelled it yet. So we still have intrauterine content, but they are no longer viable. If a woman has had 3 or more miscarriages, then she is considered a high risk because she is unable to carry a pregnancy. This is classified as recurrent miscarriages. If you do have a woman who has a history of recurrent miscarriages, it stands to reason that she would also have an increased risk for a preterm birth. She may have risk for placental previa and fetal abnormalities in subsequent pregnancies. Miscarriages can become septic, okay, so she can get an infection from this. It's not common, but it can happen. So symptoms would be obviously fever, abdominal tenderness, the vaginal bleeding may be anywhere from slight to heavy, but usually will have an odor to it. When you're figuring out how to care for women who have suffered miscarriages or abortions, think of it progressionally. If it is a threatened miscarriage, then you're going to do expected management. I mean, the os is closed, she's bleeding, but she hasn't lost anything. You may put her on bed rest, although this is still controversial, but you are going to make sure that she avoids stress. No vaginal penetration, no orgasms. She needs to keep everything relaxed. No uterine stimulation whatsoever. If it is an inevitable abortion, then emotional psychological support as well as the physical support is going to be necessary because you know it's happening, and she probably does too. It's going to be hard to deal with. But then what does she need to watch for after the fact? Okay, she needs to be aware of bleeding, what is expected and what's not, and to identify any expulsed products of conception. So, you may be able to keep her there and see it happening, but she may get sent home, so she needs to know what to watch for. If a complete abortion occurs, again, supportive therapy is going to be needed. If you're not concerned that if you had a concern that she didn't expel the products of conception, that intrauterine content's still there, then a D&C may be offered. You can always get a limited ultrasound, bedside ultrasound, and be able to see if there's anything still left inside. If it is a missed or an incomplete abortion, she may receive prostaglandins to stimulate the uterine contraction so that the uterus will expel the contents, or she can just go straight to having a D&C to evacuate the uterus. If the abortion occurs after 16 weeks, so anywhere from 16 to 20, you got to think about this fetus is, developing on, okay, gotten bigger. You're probably going to need to induce labor, okay? It's not going to be just taking them back and doing a D&C. So you're going to try and induce either with prostaglandins or you can use oxytocin. If you try to induce a labor and it doesn't happen, then she can have surgery, and that's called a D&E, or a dilation and evacuation. This is going to be a much more challenging procedure. You got to think about the uterine contents with a 16 to 20 week fetus. It's going to be a little bit more difficult to remove. You're going to have more cervical dilation, and as unpleasant as it is to think about, it's not going to come out intact. So you're going to actually have fetal parts that you're going to need to remove. It's not a good procedure. Now, once the pregnancy has terminated, however the miscarriage culminates, how do you know that everything is back to where it needs to be? Well, serial HCG levels are what you're going to follow and monitor. In a viable pregnancy, your HCG levels are going to be going up, doubling and tripling every 48 to 72 hours. That's how, one way to confirm pregnancy is actually there. Well, conversely, if you have a pregnancy loss, your HCG levels should drop. You're looking for a target of less than 5. Once HCG is less than 5, she's no longer considered pregnant. Now, if she is somebody who habitually miscarries, she may need preconception counseling in looking at future pregnancies. There's probably going to be a whole workup specifically for this type of patient. Most women who experience pregnancy losses, again, they're going to need support, physical, psychological, emotional. They'll need it from providers, from their peers, and from their community. So that's why we have our support groups available. All right, an incompetent cervix is one that just can't stay closed with the progression of the pregnancy. So premature dilation of the cervix causes... It used to be common, it's not as common anymore, is DES. DES is a synthetic estrogen that used to be given to pregnant women to stop miscarriages or other pregnancy issues. It was usually given during the times period 1938 to 1971. The doctor's thought processes were that miscarriages, preterm birth, those issues were related to a woman not having enough estrogen naturally, so they would give the synthetic estrogen. They thought it would be safe and would, prevent bad outcomes. And as a result, there was an estimated 5 to 10 million pregnant women and children who were exposed to DES in utero. The DES affects the uterus and can actually have been linked to cancers in young women. So anyway, DES is an issue. The more common thing now is your cervical procedures or trauma. If you've got a patient who had to have a LEEP procedure or a cone procedure on the cervix because she had cervical cancer, if she has a stenosed cervical os and it was gone in and dilated, anything that affects the cervix could interfere with its ability to remain competent and to stay closed. So what do we do for these women? Well, there's the assessment first to try and figure out what's going on. I mean, an ultrasound for cervical length is what you're looking at. So typically your cervix, you want it to be 3 to 4 centimeters in length. If you get a cervical length that's less than 25 millimeters or 2.5 centimeters before 23 to 24 weeks, then you're going to give consideration to placing a cerclage to support that cervix and try and keep it closed. Conservative management before you get into the surgical process is going to be, keeping her on bed rest, progesterone therapy, antibiotics, anti-inflammatory drugs. But especially if it is a recurrent situation, you are going to do something to be more supportive, and that is going to be with a cerclage. The Sharad Curve or the McDonald procedure is the one that you see, McDonald being the more common one, but kind of where they place it, is it through the walls or around the walls, is going to determine the type. And on the next slide we'll take a look at that. If you've got a woman who has had a history of incompetent cervix, repeated later pregnancy losses, so that it's going to be in the second trimester, 20, 21, 22 weeks, you may do a prophylactic cerclage, and you're going to do that 11 to 15 weeks. These procedures really and truly are done, should be done in the hospital under sedation and observation. You will need to make sure that the woman, once she has it, gets instruction. She takes it easy at home. She avoids anything that is going to have cervical stimulation, or you may even need to give her tocolytic medicines because of the manipulation of the cervix and the uterus. You may actually stimulate uterine contractions, so you're going to need to calm that down, keep it on the low side. Give her instructions, what to watch for preterm labor, if rupture of membranes, because you got to think about, these are going to be placed before 23 to 24 weeks. After that, there's no point in doing it, because if she has the baby, then you'll do the support that you can. It'll go to NICU. There's the increased risk or chance of viability up to 23, 24 weeks. That's going to be the cutoff for this. Sometimes they will remove it at 37 weeks and just say, well, if I got to 37 weeks, she can go into labor whenever she wants to. Or if she starts laboring before 37 weeks, you will need to take it out then. Occasionally, if we're going to have a planned cesarean birth, they've even left the cerclages in until the cesarean procedure was over. So here you just see an image of the two different types of cerclage, and the one on the left side is the McDonald, that is more commonly used. It's almost like a purse string in that it goes in and out around the cervical os and the cervix, and it pulls up tight so that it, in essence, cinches off and supports the cervix so that it's not going to dilate up. The Sharad Curve is more of just a circumferential inside the neck of the cervix, and again isn't done as often, but they're both equally effective. It's just McDonald's what they seem to use more. They do use a permanent suture for obvious reasons, and that's why the suture has to be cut and removed. If they used an absorbable suture, then it's not going to stay in place and it's not going to be supportive. Alright, so we're going to talk about tubal pregnancies or ectopic pregnancies. This is where your fertilized ovum implants anywhere outside of the uterine cavity. Most commonly it's going to be in the ampulla, and you got to remember fertilization takes place, so it kind of makes almost sense that it could set up there. Ectopic pregnancies are responsible for 10 to 15% of maternal deaths if they rupture, because you'll have hemorrhage and shock. If you injure or destroy the tube, then you're going to have infertility ensuing from that. A woman who is having an ectopic pregnancy will generally exhibit abdominal pain in varying degrees, depending on just how distended the fallopian tube has gotten with the embryonic growth before it ruptures. Ask when the last menstrual period is. If she has been trying to get pregnant, she may very well be on top of when her periods were. If she wasn't trying to get pregnant, she may not be able to really give you an accurate description of her menstrual pattern. She may not know if it's a delayed menses or not. And then obviously any abnormal vaginal bleeding could be indicative of a pregnancy loss beginning, or threatened miscarriage or something like that. If you've got somebody who comes in complaining of vaginal bleeding, okay, it's almost like a simultaneous thing that you're going to do, but one of the first things you're going to do is actually look at the bleeding, and you're going to be figuring out how much is she bleeding, okay? Is she soaking through a lot of peri-pads? Is she, going through things in a short amount of time? To what extent is the bleeding? And almost simultaneously, you can be finding out, are you hurting anywhere? Well, where? How bad is it? When was your last period? Are you having any other symptoms? You can look at nonverbal things. But you always want to make sure that you're assessing that vaginal bleeding, how much and how long, anytime you have a woman who presents with that. If you do have a tubal pregnancy, if you do an early ultrasound, like we talked about how you ultrasounds for dating. If you know somebody's pregnant and you don't see anything in the uterus, then automatically you have to be worried about a tubal pregnancy. The transvaginal ultrasounds, those are done 6 to 8 weeks of gestation, and so a lot of times they will be able to identify a tubal pregnancy quickly. If we see a tubal pregnancy and we can catch it before it becomes rupturous, a salpingotomy is going to let you cut into the fallopian tube to try and remove the embryo. If you can't do that, or if we unfortunately rupture, you're going to do a salpingectomy and you're going to remove the whole tube. Obviously, you can see how that potentiates infertility just by trying to save the mother from the tubal pregnancy. If she is stable and we're not worried about imminent rupture, and the embryo is small enough, so less than 3.5 centimeters, okay, on ultrasound, then we can do methotrexate. It has been proven a safe and effective way to stop an ectopic pregnancy and avert an emergency situation. If you remember from way back in the beginning, when we were talking about methotrexate, you have to be sure that the woman is not supplementing with folic acid, because the folic acid interferes with the activity of the methotrexate. You need to make sure that you counsel her on future fertility issues, and then the possibility of a recurrence of the ectopic pregnancy, and what birth control options are going to be best for her if she needs them. If she is an Rh negative woman, you're going to need to make sure that you give her Rogam or a similar product because of Rh sensitivity and isoimmunization. A molar pregnancy, or hydatidiform molar pregnancy is easier, is a type of gestational trophoblastic disease in a spectrum of pregnancy-related trophoblastic disorders where there's not going to be a viable fetus. So while anytime you have a quote-unquote molar pregnancy, everybody says pregnancy. However, there is not anything that is going to be viable or fetal that comes from a molar pregnancy. The incidence is rare. There's only like 1 in 1,000 pregnancies that are molar in type. What causes molar pregnancies, really we're not sure of. Thought processes are that it's something to do with an ovular defect or a nutritional defect in the woman. At risk are women who receive Clomid for fertility issues, women who are over 40, or your early teen adolescent females. We classify molar pregnancies as 2 types. You have a complete or a partial. Your complete results from fertilized egg that's lost or doesn't have an active nucleus in it, so it's not going to make anything. There's no fetus, placenta, or any amniotic membrane from that. Now, a partial molar pregnancy results from 2 sperm fertilizing a normal ovum. Your partial moles may actually have embryonic or fetal parts in an amniotic sac there. However, congenital anomalies are usually present, malignant transformation, potential 5 to 10%, but remember, the cause of your miscarriages and your losses in early pregnancy are most of the time attributed to congenital defects and abnormalities. So how do you know if you have a molar pregnancy in place or not? Well, diagnosis is going to be done with ultrasounds and hormone levels. On ultrasound, you're not going to see your, traditional intrauterine pregnancy and content. What you're going to see is something that we call a snowstorm pattern. That is characteristic, that is a key kind of thing that you're going to see in place of or in conjunction with fetal parts or embryonic parts. the trophoblastic tissue secretes the HCG hormone, and in a molar pregnancy, they are going to be persistently and continuously high. Typically at 12 weeks, your HCG is going to level off. In a molar pregnancy, it's just going to continue to go up. So what does the woman look like? Well, early on, if she doesn't know it's a molar pregnancy, she may feel like everything is the way it's supposed to be. Just advances like a normal pregnancy. But as you start getting out of that first trimester and getting into the second trimester, you're going to see an excessively enlarged uterus. So somebody who is only 14 or 15 weeks may be looking like she's 20 weeks. A lot of times people will think, oh, well, maybe I have a twin pregnancy or something, and that will cause them to do an ultrasound at that point if there hasn't been one before. Later on, you're going to start seeing bleeding, bright red to brown vaginal bleeding that's going to occur in about 95% of the time. Management is going to be really, really important. If they don't pass spontaneously, then you're going to need to do a suction D&C. You're going to need to make sure that you completely evacuate the uterine content. We do not want to do oxytocin induction for treatment of this situation. We want to make sure everything is out, and a suction D&C is going to be the way we do that. It is critical, I'm saying this 3 times and 3 times again, critical to instruct the patient to avoid pregnancy for at least 1 year. Remember, the HCG is going to continue to rise in a molar pregnancy. If you've evacuated the pregnancy, then the HCG levels should be back to normal. If you are having a progression to a metastatic trophoblastic disease process, the HCG of pregnancy is going to mask the HCG of trophoblastic disease. So a woman who has had a molar pregnancy must avoid getting pregnant again for at least 1 year to confirm that HCG levels are normal and that all manifestations of the trophoblastic disease have resolved. Alright, so now we're going to move into later pregnancy bleeding. First thing we're going to talk about is placenta previa. Placenta, the organ we're talking about, previa, presenting first, okay? So the placenta is implanted in the lower uterine segment, and it's going to lie either near or over the os. If it is a complete previa, then the placenta is completely covering the cervical os. If it is partial, then pretty much what it says. The placenta is going to be partially covering the cervical os. If it's marginal, it's just going to be laying adjacent to it, somewhere 0 to 3 centimeters at the margin of the os. Placenta previa is identified, diagnosed, discovered, however you want to say it, on ultrasound, and it'll be a transabdominal ultrasound, and it's usually seen when they do the mid-pregnancy anatomy scan. The woman who does not have an ultrasound to tell you that it's there, if she comes in, she's past 20 weeks, and she is reporting bright red bleeding, but she's not having any abdominal pain or any pain at all with this. So vaginal bleeding, no pain after 20 weeks, you immediately need to start thinking about placenta previa, and if you haven't done anything diagnostic to identify it, then you're going to get an ultrasound done. Expected management is how we manage these. It's, educational up to the point of delivery. The education is absolutely nothing goes into the vagina, period, until delivery. So, no fingers, no toys, no penis, no nothing goes up in there, okay? When she comes into the hospital, if she's in active labor, you are not going to do a vag exam, okay? Remember, nothing in the vagina, so no sterile vag exams or anything like that. Cesarean birth should be planned if it is a continued confirmed placenta previa. You do not want the fetus to come out that way. There's no way for it to come out except through the placenta, so that is going to be a significant medical emergency if it happens. So delivery method for identified, intact, managed placenta previa is cesarean birth. Alright, so we're going to talk about late pregnancy bleeding now. If the placenta separates from the uterine wall before the birth of the fetus, we have a premature separation or a placental abruption. Abruption occurs in 0.4 to 1.3% of pregnancy, so it's not a very common thing to have happen, but it is a OB emergency when it does. Hypertension has most consistently been identified as the causative risk factor for the abruption, but other things that are associated with it include cocaine use, if there is blunt force trauma to the abdomen, so if the mom was in a car accident, if she received injury to the stomach, if she was kicked in the stomach, you got to think about abuse. It increases in pregnancy. So anything that's injurious to the abdomen. Smoking, again, because of the vasoconstrictive events, which is going to give you the same hypertensive kind of concerns, and if she has a history of a previous abruption. All of those factors have to be considered. When you are determining the degree of abruption, if you look in your book on 653 at table 21.7, in the bottom half of, well, actually, in the left side of it, it's going to give you the grade breakdown of the placental abruption. So grade 1 is going to be a mild separation, 2 goes to moderate, and 3 is going to be severe. So you've had over 50% detachment going on there. As far as what you may see or feel with it, you know, in the grade 1, you probably aren't going to have a lot of pain with that. Grade 2, you're going to see pain associated with it. Grade 3 is going to be agonizing pain, and you are going to have a lot of blood that comes out with that. So, clinically, vaginal bleeding, and it's going to be dark red. Think in comparison to the placenta previa, generally that is going to be a painless, bright red vaginal bleeding. Placental abruption is going to be dark red vaginal bleeding, and you can have it as a painless if it's just a grade 1, but grades 2 and grade 3, you're going to have abdominal pain, uterine tenderness, you may have some rigidity noted, but you're also going to have that dark red vaginal bleeding. So if you've got a patient that is hypertensive or has a history of smoking or drug use, cocaine use, and she starts complaining of abdominal pain, she's having, you know, elevated pressures, and you start seeing dark red bleeding, you think abruption. If she is someone who has a history of cocaine use, hypertension, you know, maybe a tachysystole, you know, a high resting tone on the uterus, if she's having abdominal pain, even if you're not seeing the bleeding, you still have to think abruption, because it may be that the bleeding is just not manifested because of where the abruption is occurring. And I'll show you an illustration of that on the next slide. Abruption is not always going to be a good outcome. You've got literally minutes to get this woman into the OR and to be able to get the fetus delivered so that you can save the neonate and so that you can save the mom. Perinatal mortality when you have an abruption is 20 to 30%, which is pretty high. How you're going to take care of this, other than a C-section delivery, because if it's abrupting, you're going to have internal bleeding and everything. You're going to, depending on the severity of the blood loss, manage that. If it's, mild and you can go in, you can get it taken care of, they may not need replacement products, but there's a good chance you're going to be needing to give oxygen. You're going to need to be having some blood replacement products on hand. So here, if you look in the top left picture where you see partial separation, but you have a concealed hemorrhage. So the placenta is only partially detached, but the bottom edges and the top edges are still secured to the uterus. So you may not have evident bleeding associated with it, but you should still be able to say, okay, is my mother having any pain associated with this? If you look to the side of it, you've got a partial separation that's actually detached at the edge. So yes, there you would expect to see some bleeding occur. And then if you look at the bottom picture, you've got a complete separation of the placenta body, but it is concealed because it is still, the edges sealed in there so that the blood can't escape. So pain is going to be present with a placental abruption. Bleeding may or may not be. If you see the bleeding, it's going to be dark red blood. So make sure you keep the differences straight. Placenta previa, painless, bright red bleeding. Placental abruption, painful, dark red bleeding or no bleeding. But look at your patient history, patient status to be able to determine which way it's going. Alright, so now we're going to talk about bleeding that can be associated with cord or placental variations. Vasa Previa or velamentous insertion of the umbilical cord is not a very common thing. It has been associated with placenta previa or multi-fetal pregnancy. In a Vasa Previa, the umbilical vessels branch out at the membranes. They may even course through the membranes and go into the placenta. So if you can imagine an umbilical cord in your mind, it is completely wrapped in the Wharton's jelly all the way down to where it enters usually into the center of the placental disc. Okay, and then you have the vessels that just run into the placenta. With a Vasa Previa, you lose the Wharton's jelly at the distal end of the cord where it's going to attach into the placenta. So there will be some inches where the umbilical vessels do not have that protective wrapping around it, and so they are just going to branch out, kind of run through the membranes, and then they will go into the placenta. If you have Vasa Previa and the umbilical cord or the vessels of the umbilical cord are lying where the membrane is over the placenta, over the cervical opening, and you go to do an amniotomy and rupture the woman's bag of waters, you could theoretically use your amni hook and go into the unprotected umbilical vessels. You can tear them. You see where I'm going with this? You're going to have hemorrhage. So this is a fetal emergency. It may rapidly hemorrhage out and death will ensue. A placenta subcenturiate is really just almost like a ancillary placental lobe that is not attached to the root placenta, and you have vessels that are connecting into it. And then your battledore insertion of the cord is where you have a marginal insertion. You don't have it inserting into the placental plate the way you traditionally would, and again, increased risk for hemorrhage. I've got a couple of pictures and slides coming up so that we can look at what each of these things are. So while this isn't the best image, it does give you all three of these things in one place. So in the top one, you see you have that additional lobe from the placenta, and you've got the vessels that are unprotected traversing over to perfuse into that lobe as well. In the middle picture, you have the marginal battledore insertion of the cord. So you can see instead of the cord coming centrally into the placental plate, it is off to the side. And then at the bottom, you've got the velamentous insertion, and then you can have the Vasa Previa with the vessels if they are actually unexposed and lying over the cervical opening. I want us to look at the next picture because that's going to give us, I want to talk a little bit easier about the velamentous insertion so you can see it. So here we have a nice up-close picture of a velamentous insertion and the Vasa Previa. So if you look at the umbilical cord all the way to the far right of the picture, you can see how it's coming in. It's, you know, encased in the Wharton's jelly, but then you lose that Wharton's jelly and you have just the unexposed vessels migrating through the membranes as it goes into the placenta for insertion into the placenta itself. So you can imagine, take a look at those vessels there. Can you imagine if the amniotic sac is intact, okay, you've got those vessels laying down over the cervical os. You don't know it's there. You put the amni hook up inside to rupture her waters, and the amni hook actually hooks into the amniotic sac, hooks into one of those unprotected vessels, and then you pull out. OB emergency. Alright, so moving into clotting disorders. And this slide is really just a refresher about normal clotting. You know, there's a balance, a homeostasis, if you will, between, you know, hemostatic properties to stop bleeding and then the fibrinolytic systems that will break down the clot to restore circulation. The hemostatic system you know, is involved in a life-saving process. It's what keeps us in balance, you know, to stop flow of blood from injured vessels through the formation of an insoluble fibrin that's going to act as a hemostatic platelet plug so that we don't bleed out and exsanguinate. Coagulation processes involve the interaction of the coag factors, your clotting factors, where each factor is going to sequentially activate the next factor. You may remember this as your cascade effect. Once that fibrin clot is formed, we've stopped the bleeding, we are now stabilized, the fibrinolytic system is going to come in and it's responsible for breaking down that clot. So the fibrin clot is split into fibrinolytic degradation products. So that's an important thing to remember, and once that clot is broken down, then circulation is restored. Alright, so talking about DIC, disseminated intravascular coagulation. Pretty much this is a bad thing because the woman's using up all of her clotting factors, clotting cascades, and then she's overactivating the fibrinolytic system to break down the clotting factors, so she starts bleeding again, so then she uses more of her clotting cascade, so it's just a never-ending cycle. The multiple fibrin clots that are formed from this kind of strangulates the blood cells, red cells, as it tries to get through the fibrin-choked vessels, and so you have destruction of the red blood cells, and you have the hypoxia that occurs. So clinically, what you see with DIC is clotting, bleeding, and ischemia. So things to think about whenever you're caring for an at-risk pregnancy, at-risk labor, is if they have HELLP syndrome or if they have preeclampsia, they're going to have an increased risk for DIC. If they have an infection of some kind, gram-negative sepsis, that's a condition that can trigger DIC to happen. So you want to make sure that you look at all of that. Management is to make sure you fix whatever the problem is. So if it's HELLP syndrome, if it's preeclampsia, if it's sepsis, whatever, you want to fix what the problem is. If you're worried about sepsis from a fetal demise that was not discovered, and you know now she's become septic from it, then you need to remove the fetus and the placental content. You're going to replace the fluid loss, blood component therapy. Obviously, oxygenation and perfusion is going to be very, very important. Vitamin K and your recombinant activated factor 7 may also be considered, because you've got to look at those clotting factors she's lost and what can you do to get them back in line. Okay, so we're going to look at infections acquired during pregnancy. Sexually transmitted infections are responsible for significant morbidity and mortality in pregnancy. There are more than 20 known STIs to affect pregnancy outcomes. For your pregnant population, factors that increase the risk of having a sexually transmitted infection, they're going to include things like adverse lifestyle choices and behaviors. They may have multiple sex partners, they may use unsafe sex practices, or they may have substance abuse. While there are specific recommendations for treatments of your STIs, in pregnancy, treatments may need to be modified to protect the fetus. So the first set that we're going to look at is going to be categorized as your torch group. Your torch infections are capable of crossing the placenta, and they can cause fetal harm. If you look at table 2110 on page 662 in your textbook, it gives you a breakdown of maternal, fetal effects, and then the counseling for that. So the T is for your toxoplasmosis. Most infections are asymptomatic. Women are immune after the first episode unless they are previously immunocompromised. So if they get the toxo once, then they should be immune for it. With the toxoplasmosis, you got to remember that exposure to litter by infected cats is a no-no. So women who are pregnant, if they have cats, they're told do not go near the kitty litter, the litter box. You do not change the kitty litter box. Somebody else should do that for you. The O stands for other infections, so your hepatitis A or B. Remember, A is fecal oral and B is blood and body fluid. You can get vaccinated with hepatitis B, and it shouldn't affect the fetus, so that's not a problem. Perinatal transmission of hepatitis A virtually never occurs according to your text, so that's pretty good. If you've got a mom that you're worried about safe sex, or her lifestyle and everything, make sure that you preach safe sex practices to her. The R is for your rubella. Just make sure that you remember vaccination in pregnancy against rubella is contraindicated, that they should wait at least a month after being vaccinated before they get pregnant or anything like that. The most common fetal anomaly associated with congenital rubella is deafness, eye defects, or central nervous or cardiac defects. CMV, this is a virus, and it's actually a herpetic virus. The way toxoplasmosis usually didn't come back again, CMV, you can get it again. So the presence of CMV antibodies does not prevent reinfection. So that's an important thing that we need to make sure our moms know. And then herpes. I mentioned it a little bit when we talked about integument on the last lecture. Herpes Simplex, especially if they've got type 2 genitalia, you don't want them to have an active outbreak whenever they are 36 weeks or beyond, because you don't know if they're going to go into spontaneous labor. You don't want them delivering at home. You don't want the fetus contracting HSV as it comes through the birth canal. So typically at 36 weeks you're going to start suppressive therapy. Acyclovir is pretty common to be utilized for that. If there are active outbreaks at the point of delivery, a C-section birth is indicated. Alright, so if we're talking about urinary tract infections or the renal system, asymptomatic bacteriuria is where you have bacteria in the urinary tract, but she doesn't know it. She doesn't feel it, okay? All women should definitely have a urinalysis on their first prenatal visit, and then if there's ever any question, go ahead and do another one. if you don't treat asymptomatic bacteriuria, 40% will develop a symptomatic infection. So our ideal is to not have any infections in pregnancy at all. You don't want to just throw antibiotics at people, but you have to think about, what am I doing, and if I don't do something, what's my end result here. So keep in mind, 40% will develop a symptomatic infection if you don't treat them. Cystitis is a bladder infection. You know the signs and symptoms of cystitis: urgency, frequency, may have pain with urination. Typically, if it is caught early, you're going to just do a 3-day course of antibiotics and have it taken care of. Cephalexin, Keflex is going to be pretty typical. You're not going to use your quinolones in pregnancy. For your pyelonephritis, this is where we start getting into some serious trouble. So if you have not managed the asymptomatic bacteriuria and it progresses to a bladder infection, cystitis, urinary tract infection, and you don't treat that adequately, it is going to progress up and get into the kidneys, and you're going to have pyelonephritis. Pyelonephritis is one of the prime reasons that women get admitted into the hospital, especially in their second trimester. If you don't treat pyelonephritis and get it under control and cured, you can actually run the risk of preterm labor and preterm birth as a side effect of the pyelonephritis. So very, very important to make sure that you manage the urinary system well. Treatment for pyelo is going to be done with ceftriaxone or Rocephin, and it is a hospital management. Patient education is going to be very important because you are going to need to make sure that they understand the importance of hydration, observing their symptoms, going to the bathroom frequently, okay, when they feel the need to void, they need to go and void, and to make sure that they take their medications appropriately. One of the biggest reasons that we have reinfections and continued infections and drug resistance is we'll take the first few days of an antibiotic, we start feeling better, we say we're cured, and we quit taking it, and actually you're not cured. And so the organisms actually have the capacity to mutate against the antibiotic and not be effective. So you need to make sure you tell your patient, take all of your medicine exactly as prescribed, and report any unusual symptoms to the provider. If you remember us talking about, just the changes the body goes through as the pregnancy advances, do you remember that picture of how it may be difficult to identify an appendicitis because everything's going to get displaced, and where you expect the appendix to be in later pregnancy is not where it is. So appendicitis may be difficult to assess and determine on a pregnant abdomen. If you are concerned about appendicitis, you're going to be looking for traditional signs and symptoms the way you normally would. Nausea, vomiting, increased white count. But doesn't that sound familiar for things that can happen in pregnancy too? So you want to do an ultrasound in the first and second trimester. That's going to be the best way to determine if you have a concern for appendicitis. If you get into the third trimester, then you're going to need to do the helical CTs. That's going to give you a little bit better imaging, and if you can't get imaging done with that, you can always go into the MRI that we talked about in the last lecture. Surgery is what's going to be necessary to do this, just like you would with any other appendicitis case. Surgery is going to be indicated because if you have a rupture of the appendix, and especially if you get infection, then preterm labor and even fetal loss could happen. Cholelithiasis, cholecystitis, gallstones, or gallbladder infection, they're both pretty common in pregnancy, probably related to hormone levels, but women with acute cholecystitis, they're probably going to be a little intolerant to the fatty foods that they may have a tendency to want to ingest being pregnancy, but they will also have abdominal pain, and it may radiate kind of up the back, around the shoulder. You may have an elevated temperature. If you do an ultrasound, you should be able to see the stones in the gallbladder, so you'd be able to determine that as well. Some women do have gallbladders removed in pregnancy, especially if they have gallstones and they start being very obstructive and they get jaundice. Then we don't want to get, peritonitis or worse conditions. So definitely we're going to need to operate on those. Best time to do it is in the second trimester, because you're less likely to have teratogenic effects from anything that you're doing, any medicines that they need. You're less likely to have the risk of miscarriage or a preterm birth. Lap choles seem to be the way that we're going with this. If you are looking at your gen problems, ovarian torsion, ovarian cyst, and a prolapsed uterus. Now, ovarian torsion is going to be something that's an emergency, because if you've got it twisted, then the ovary is going to have circulation cut off, it's going to necrose, and it's going to die. So we certainly don't want that to happen. So if you have an ovarian torsion, then that's going to be an interventional emergency. Ovarian cysts are uncomfortable, but they should be okay. Now, they can be operated on as well if they are getting larger. If you've got, I've seen ovarian cysts like the size of softballs, and so you can imagine that that is not going to be conducive to having a successful pregnancy and enlarging uterus on the inside. A prolapsed uterus, hopefully you're going to know that there's the potential for prolapsed uterus before you get into pregnancy. If you aren't aware of that and the patient sits up and increases that intra-abdominal pressure by sitting up, you may actually see the cervix protrude beyond the vagina. That's not good. So they may need to have a structure, some assistive device put in place to help support the uterus and the pelvic floor through the rest of the pregnancy. In considering trauma during pregnancy, the significance is that about 8% of pregnancies will be complicated by trauma, and trauma is the leading cause of non-obstetrical maternal deaths. Special considerations do need to be given for the mother and the fetus, pretty much just because of the physiologic alterations in pregnancy, the adaptations the pregnancy has gone through, and the presence of the fetus itself. It stands to reason fetal survival is directly dependent upon maternal survival. If she's not saved, it's going to be hard for the fetus to survive. So your pregnant woman should receive immediate stabilization and care in order to optimize our fetal outcomes. Things that can influence the pregnancy and in association with trauma, a lot's going to be dependent on how pregnant she is. If it's very early in the pregnancy, it could be that, the uterus is still small, the fetus hasn't gotten up in the way, so there's not that potential for abdominal injury. What is the trauma that she's experiencing? Is it blunt force trauma? Is it penetrating trauma? Is it lacerations? Is it something to interfere with oxygenation or circulation? And to what degree is the direct disruption of uterine perfusion, and how is that going to impact the fetus? So looking at your maternal physiologic characteristics, you got to think about what adaptations has her body undergone to help guide what you're going to do and how you're going to manage this trauma. Where is the uterus in all of this? How pregnant is she? So is the uterus, up above the belly button and under her diaphragm? Where is the bladder in all of this? Is everything still low or is it high? If she has the elevated progesterone that comes with the pregnancy, remember that is a smooth muscle relaxant because we don't want the uterus to be overactive. Well, you also have it working on the GI tract. So remember, we have the delayed gastric emptying. So if we have delayed emptying, we can still have stomach content. So if we go to doing anything with her, then there's the potential for aspiration. obviously she's not going to be able to tolerate hypoxia or apnea for either her or the fetus. So that's going to be an issue. We want to avoid supine positioning. We know that from almost day one in class because we want to promote circulation and perfusion as much as possible. When you're thinking about circulating blood volume, she has compensated because by the third trimester, she's had an increase of 40%, circulating blood volume to be able to prep for the possibility of, or the probability of what blood she's going to lose in delivery and such as that. So you can't use that as a barometer for how well she's doing because she may not show decompensation signs until she loses 1,000 to 2,000 milliliters of blood. We know fetal monitoring is pretty much one of the best, if not only, ways that we have of determining fetal status, okay? And if we can get a reflection of what the fetus is doing, theoretically it's going to give us a reflection of what mom is doing. So, they say fetal monitoring works as an oximeter of internal maternal well-being, and you have to understand that, if she has well-being, so that means she is oxygenated and she is perfusing appropriately. She's not going to shunt away from the uterus and away from the placenta. She's going to continue to perfuse her entire body appropriately. So it's going to go to the uterus, go to the placenta, and go to the fetus. So if you see a quote-unquote happy baby on your fetal monitoring, then you have to presume that your maternal assessment is going to be a positive and not a negative. When you're thinking about the ways trauma can happen on our pregnant mom, remember we talked earlier about blunt force abdominal trauma, and that being one of the causative reasons for a placental abruption. Well, your motor vehicle accidents will account for the greatest number of blunt force traumas in our pregnant population. So that's why you have to, caution people about making sure that they're wearing their seat belts appropriately, and how far are they in the pregnancy whenever they're driving. Because you got to think about somebody who is getting into that last month of pregnancy. If they're like me and they're short and they got short legs, they've got to, pull the seat as close up as they can so that they can reach the gas pedals, but then the steering wheel is right there in front of their abdomen. So if they have any kind of impact whatsoever, then they've got the steering wheel that slams into their belly. So you're going to definitely need to assess, are they having any pain, any tenderness? Do you see any bruising or anything like that if you have a motor vehicle accident? Penetrating abdominal trauma, this is going to be your bullets or your stab wounds. And yes, people do get shot and stabbed when they're pregnant. If you have a stab and you have the object still inside, so a knife, a pole, or whatever, remember we do not remove objects because if you remove it, then you may open up worse bleeding, because at least if it's in place, then it is occluding the vessels that it has disrupted. The KBT, the Klein-Hauer-Betke test, remember we talked about that whenever we were doing our assessment of fetal well-being. We were talking about the PUBS test. A KBT is simply a test to see if maternal and fetal hemoglobin and blood are mixing or not, to see what the risks are there. When you're looking at your thoracic trauma, pulmonary contusions, result from nearly 75% of your blunt thoracic trauma. Obviously, pulmonary contusions have the potential to be life-threatening. You want to get those under control. If you have any type of chest injury, you have to be concerned about that. If you have penetrating wounds into the chest, then you have to worry about a hemothorax or a pneumothorax, and unless you can get those things reversed, the lung's not going to be able to expand appropriately, so you're going to have interruption in respiratory function. Alright, we've already identified the fact that immediate stabilization of the woman who's experienced trauma when she's pregnant is key, priority number one, okay? What you're going to do, your assessment, your intervention, your management, it's the priorities are the same in pregnancy as they are in non-pregnancy. And what you have to remember is this fetus, we're taking care of mom, but we're taking care of fetus too. And if we don't get mom through this, we can't expect the fetus to survive it. So you're going to start with your head to toe. You're going to do the same type of primary survey and intervention as if she were non-pregnant. So your approach is CABD. Do I need to do compressions? Am I having a circulatory problem? Do I need to get the heart going? What is my airway pattern? Is my airway open? Can I get to it? Can I get air in and out? Am I breathing or not? Do I need supportive ventilations? And is defibrillation necessary? Venous access, because you don't know what you're going to have to infuse. Usually it's going to be a large bore, 18 minimally. In the field, they're probably going to put a 16 in so that they can bolus the IV fluids and at least try and get some circulatory pressures increased. They may need to give blood. They may need to give meds. So you want at least one, if not two, venous accesses so that you can get volume with IV fluids, blood products, medications, things like that in. If you're worried about what type of blood to give, in extreme emergencies, O-negative blood can be administered without cross-matching. You know that. If pressures are a concern, vasopressors to be able to bring the blood pressure up so that that's going to enhance perfusion. If you've got a concern for choking, patient may need a Heimlich Maneuver as if she weren't pregnant, but traditionally the non-pregnant person, when you do a Heimlich, you put your arms around them and you cross your fist and you put it at the level of the umbilicus. You can't do that with a pregnant woman. So you're going to need to put the arms actually up over her, across the chest, up at the top, and you're going to do your compressions in that way. If you look on page 671 in your book, it will actually give you a depiction of how to do the Heimlich on a pregnant person. If she becomes unconscious, then you're going to need to be behind her, and you're going to need to support her to the ground. So don't let her drop, help her down. You're going to need to activate EMS and begin CPR. Once everything is taken care of, you're going to go back and you're going to do your secondary survey once she is stabilized, just to take a more complete, detailed look of what's going on, what do you see, what do you need to do interventionally. Fetal monitoring, if you have the capacity to do electronic continuous fetal monitoring, that is going to be the ideal, because then you will be able to see fetal activity as well as uterine activity. Depending on what the trauma is and what the results are, if it's blunt force trauma and you've got, placental abruption, partial detachment, any injury like that, then a cesarean birth is going to be necessary so that you can save pretty much both the woman and the baby. Again, remember your Rh negative women, depending on where they are in the pregnancy, is it past that 28 weeks where they could have gotten their ROGAM? If they have not received it yet, that's a consideration that you need to make. If it is a minor trauma and she's going home, then once observation with fetal surveillance shows that the fetal well-being is good, her vital signs are stable, there is no bleeding, no uterine activity, NST is reassuring, may even do a BPP just to take a look at everything. If it's all good, then they're going to let her go on home. They will give her instructions on what to watch for. Make sure that you are observing uterine activity. If you start experiencing any increase in contractions, start having any pain, see any bleeding or anything like that, you need to report to your provider immediately. So that was a lot in pregnancy at risk gestational conditions. It's pretty thorough, so please listen to it again, correlate your notes with what you hear, and then we will talk about it in class on Monday. Y'all, thank you. See you on Monday.